Dr. Martin Wale is an MD from the UK with postgraduate training in pathology and microbiology. In the 1990s, he established a regional communicable disease surveillance center, which became the first regional unit in Europe to develop a capability for responding to chemical and environmental hazards. He was the first regional director for the East Midlands, during which time he created a unique partnership linking a medical school, veterinary college, city hospital, and strategic health authority to create the Nottingham Institute for Population Health. Later, he became an executive medical director for a large acute trust in Yorkshire. He was awarded a fellowship at the NHS and working on patient safety. Meanwhile, he was also completing an MBA, also focusing on innovation and improvement in the NHS. In 2009, Dr. Wale joined the Vancouver Island Health Authority as Executive Medical Director for Quality, Research and Patient Safety.
I've been involved in leadership pretty much from as soon as I left medical school, because I went and worked as a commando medical officer with the Royal Marines, which is a very a specific style of leadership and a specific style of followership. It's a system, if you like. When I left the Royal Marines and went back into the hospital service, so in one sense you're already focused on the fact that there's a system rather than just a patient. And moving back into the hospital system took that perspective with me. My professional specialisation is microbiology, but that includes infection control. And one of the decisions I took fairly early on was to also dual specialise in public health. And so again, you start to broaden that out. And the reason I did that was that I found that I could achieve more by operating on a more broad basis. And so the move into management followed the same sort of lines. I could achieve more by adding management tools to the set I was already using. I don't know. I've always looked at things from a broader perspective than just the one-to-one interaction, for example, with a single patient. It's always been a question of how do we do this better? Why, if we get 6 of these a day, can't we do something special for them? Why is it that we can't get smarter at dealing with these types of patients? You still have to maintain the balance with the one-to-one clinical practice, because this is all about relationships and it's all about trust, which has to be built on a one-to-one basis. But there is a system component as well, right from the very earliest stages. So it wasn't that I crossed the Rubicon in one sense or suddenly changed from being a clinician to a manager. I actually, the two work seamlessly. I have a clinical practice which is limited to infection prevention and to antimicrobial stewardship at the moment in my current role in Canada. So again, having moved away from individual patient contact, until I left the UK, I was still involved on a day-by-day basis with things like ICU ward rounds in microbiology. One of the early surprises, and I think it's something that I see very frequently in physicians who are going into or leadership or who feel that they move into leadership roles, is the fact that they, or I in my case, sort of assume that because you had an understanding that everybody else would share that understanding. And so I had a couple of instances early on where I came up with what I thought was a really good idea and spectacularly failed to sell it to senior management because they just didn't see things the same way. So that sort of thing, just because you've got a good idea. And a lot of my work now is actually about helping physicians to mobilize ideas within their systems, because they may have very good ideas, but they've got no chance of no understanding. of how to make that idea fly within an organisation. So a lot of the work, as I say, I do now is about helping those ideas and getting them sorted out. I can give you specific examples. Before I left the UK, I was working in a multi-site acute trust in Yorkshire. And we had a group of colorectal surgeons who were known for being difficult and out of sorts with the organisation. And the main hospital was moving into a new site, so an entirely new hospital. And they had no idea about how. They had an idea about the sort of service they wanted to operate, but they had no idea about how to work with the organisation to get that sorted out. No idea how to write a plan, how to engage the key stakeholders in the organisation with how to get their interest, if you like, in what they were doing. And I worked with them over about a 9-month period. And they went from being the group that was right at the back of this implementation to being the very first group who got themselves sorted out and the first plan that was accepted for the move of the service into the new building. And completely changed their approach to this. And suddenly they went from being the organisational bad boys to being the organisational poster child for how to do this. I think it's a role which is deeply and fundamentally conflicted, because on the one hand, and you see this perhaps more clearly in a model like the UK than you do in Canada, but I think it still applies equally truthfully here. On the one hand, you understand the system and if you like, hospital management or health authority management or whatever it is. On the other hand, you understand the patient perspective. The fact that you try and the two, there will always be tension between the two. And the fact that you try and reconcile the tension between the two, both at an organisational level, but you have to reconcile it at a personal level as well, is very challenging sometimes, because what it means is that neither side will trust you. And so particularly with a chief medical officer role in a trust in the UK, where the physicians are directly employed, and you would think it would be more straightforward, you're still fundamentally not trusted by either the physicians or by the management, because you always have that fundamental contradiction. In terms of working with physicians, it is a trading economy, and you don't go in just as an individual. You have to build up a stock in trade of being a person who is respected with integrity within that environment before you can become effective.
I think that's important as a physician.
I think it's important anyway, but it's particularly important as a physician, because you need, on the one hand, that stock in trade, that in the trading economy, your integrity and your personal presence is what allows each side of the organisation to trust what you're doing. And so if you really want to produce change, both of them have to trust you, and both of them have to understand where you are in that equation. It's absolutely fundamental. You have to have the relationships. And when I went into Mid-Yorks, this trust in Yorkshire, at short notice as Chief Medical Officer to help them out. And I went in with a hastily constructed plan based on 2.5 years at that stage of experience of improvement methodology and doing some good stuff in organisations, and I completely failed to engage at all, because the place had already been improved to death, and because you can't go in without doing sort of a diagnostic scan of what the organisation is like. So when I came to Canada, didn't attempt to engage in any way other than relationship building at first. And having got those relationships in place, people talk to you, so you start to develop a deeper understanding, and the deeper understanding allows you to get a different perspective, and that different perspective allows you to start to try out things around change. That's very true, because you can't. I don't know to what extent it's my approach or to what extent it's a general thing, but my approach is based on being impartial. So, for example, particularly when you're dealing with physicians, if you're dealing with an issue, you start with a blank sheet of paper rather than with, you know, a complex set of preconceptions. And no, every idea gets a fair hearing, and that's a really I found that a very good stance to take, because again it means that people come to you because they know they'll get a fair hearing for whatever it is, and it works with disciplinary matters, it works with ideas, it works with problems they have with service delivery. Because you're impartial, you can't be seen to be partisan, you can't be allied to one particular group. And also it comes down to the fundamental contradiction in the role. On the one hand you're a physician, but the physicians won't trust you. On the other hand you're a senior manager, but your fellow senior managers won't trust you because you're a physician. So you end up in a place which is not a bad place, but it wouldn't suit everybody. I think the real issue with innovation is that people see a problem, have an idea, and think that innovation is about implementing that idea. It isn't. The real issue is about properly understanding the problem and looking at, and the NHS Institute talk about understand and reframe. And so you spend, I think for any sort of intervention to be successful, you have to spend quite a long time trying to understand and reframing it. We had this was the third or fourth Clostridium difficile outbreak we'd had in the facility. So again, very sensitised. We'd been pilloried in the local media for it. So it's a very highly sensitive thing. And people are very keen and determined to sort this out, and as a result, rather than apply, when you have an outbreak, one of the very first things you do is come up with a case definition which defines what's a case and what's not a case. What I didn't realise at the time, and nobody else in the team realised at all, was that case definition wasn't being appropriately applied, and we were getting all these other people who were being tested, who were being lumped in as cases when they weren't really cases. What it led to, when I went into on the first of these 3 days, there were 38 people in a 248 bed facility on isolation precautions. Having realised what was going on, we actually changed our policy around MRSA. We changed our policy around vancomycin-resistant enterococci. We changed our policy around C. diff within the space of 3 days. The policies had been tried elsewhere, and we were readying them for rollout. But the fact remains that I put them in a very short space of time, in an outbreak situation, in a facility that was under considerable stress, which is quite a high-risk thing to do. What it did is it reduced the number of people. What it did on a superficial basis was reduce the number of people on precautions from 38 to 15, and that enormously relieves the burden on nursing, it relieves the burden on housekeeping, for no additional risk. But what it also did was it took people from the first order change of thinking about, oh, I have all these tasks to do, to thinking about how are we using precautions, and we're moving to a risk-based approach to using isolation precautions. So the fact that we changed three things all at once actually, I think, moved us to second order change. So really quite a complex example, but I would never ever have got to a solution like that. And we declared the outbreak over a week later. I would never have got to a solution like that without that period of understanding. My background includes an MBA, and so I have a healthy respect for competition as a driver of standards, and certainly in healthcare. And my own perspective is that using it to lead organisations to differentiate on quality is actually a strategy that I like to use. From a UK perspective, competition was introduced as a means of, I think, dealing with overcapacity of acute care in big urban centres, particularly London. Lots of oversupply of secondary and tertiary care beds, and so put in a competitive system that will effectively, if you like, drive out surplus capacity. I think it worked reasonably well in the big urban centres. I think it didn't work at all in places like Lincolnshire, where the population density is much lower, and where people have got a choice of going to the hospital, which is 15 miles away, or going to the hospital, which is 55 miles away, and it's not really a choice. So competition, and this is patient, this is using the patient to drive competition, patient-centred funding to drive competition. I think it was an interesting experiment. I think it has its place in urban centres. I'm not at all sure it works. I think a collaborative model is much more effective, where you need a joint, where you've got a sparse healthcare system, and it needs to work to maximise the use of those scarce resources across a big area. I think I've already alluded to it. It's those sort of early steps where you have a brilliant idea and you signally fail to get anybody to engage with it because it just doesn't translate. And I think that after the fact, you can see that idea, whilst it was clearly important to me, didn't relate to the organisation's priorities or the way the organisation was going. Most ideas have their time, and if the time is not right for an idea, then don't progress it. Just put it on the back burner, let it sit there, forget it for years, or its time may never come. But if you have the right idea at the right time, and you have to get the idea has to get support from multiple constituencies within an organisation, and so the timing has to be right for that. Again, having come from a background of improvement methodology, I deliberately seek to try stuff out in the expectation that it will fail. I deliberately introduce ideas when they're 80% finished and take the other 20% of their improvement, actually knock the corners off in practice. And that's, in one sense, that's a recipe for somebody who's in a hurry. And it does increase risk. I mean, the example that I gave you about putting the multiple policies in during the outbreak, the policies weren't perfect. The policies, we actually worked with frontline nursing staff to revise the policies, and that changed our approach for the whole organisation because they weren't ready. But I made them ready, or we made them ready during the outbreak. By trialling them in practice. And so I think failure in that sense, and working with people, constantly sort of reassure them that I do not expect an idea to be right all the time. So you don't start off with an idea expect it to be perfect and that it'll fly straight away. You start off with an idea, and I'm starting to now again in the organisation, we release policies with a view to revising them at 3 months or 6 months, because I don't expect to get them right. So we'll knock the corners off them in practice. So failure is built in as part of the learning mechanism. And therefore the effort goes into mitigating the impact of that failure. You have to do stuff which is completely different, I think. I think it's very important to maintain a balance between work and non-work. I've not had that balance right in the past, which is why I have 2 divorces behind me and things like that. But I think it's very important. I mean, I will take time to do fitness. I will take time to do stuff like kayaking and walking. And you have to program that in. Yes, I do my share of early morning and late evening meetings, but you have to allow yourself some slack. You have to, anyone can burn themselves out, and you have to build in the mechanisms to give you enough slack to be resilient. There'll be times when things won't go well. There will be times when things will go very badly, and where progress is measured almost in just continuing to be there and continuing to keep going. And it won't necessarily last very long. And sometimes just a few extra ounces of effort will produce a situation that will change. So you have to have that resilience. I like seeing cultures change. There is a myth around that culture change takes 10 years and is very difficult. It's rubbish. Culture change can take a matter of months, and it's about opening people's eyes and enabling them to do stuff within an organisation. The group of physicians that I mentioned in the colorectal surgeons in Mid-Yorks, as I say, regarded as a hopeless case by my predecessor as CMO and a number of his predecessors, and yet opened their eyes suddenly, and everybody else in the organisation stood up and took notice, because suddenly you've got a group who've been known to be intractable making progress. And somebody said to me, one of the senior nurses walking down the corridor said, people are smiling again. And that's the sort of thing that makes it worthwhile. I light fires in organisations. I foster improvement. You can't tell what's going to work. You can't tell who's going to pick up the torch. But once that ball of making things better starts to roll, that's what's really exciting. And don't attempt to control it. Just attempt to support it, nurture it, and the whole organisation can change quite quickly. Mid Yorkshire went from being a basket case within 15 months to getting an award for the most improved trust in the region. It was off the Department of Health's worry list. So big changes in a short space of time, and that's cultural as well as just the indicators.